medically experienced people. We're able to teach the students sickle cell compatibility charts at the early age. I also want to emphasize that sickle cell education at a very early age is important because this knowledge sticks and they learn it forever and they know the right thing to do. You know, we teach them, like, we break it down to them, just like the way they learn multiplication tables, you know. So since then, we've been able to do a lot. After that experience, we also were able to, you know, do some free testing for some secondary school students and their parents and teachers as well. Joined the Red Umbrella work for the sickle cell advocacy, and did a lot of other things I can't really mention here, but just still for the same goal to reduce the sickle cell burden in Nigeria. And I want to also emphasize that the essence of pain management for healthcare workers, it cannot be overemphasized. And I just want to implore and encourage the organizers of this great events that this is a great initiative, and the data analysis, everything that has to do with like sickle cell management and care is very important. And I want to implore health workers to continue to do their little bits. And yeah, thank you so much for this opportunity to be speaking amongst these wonderful people here. And I appreciate it. Thank you so much. Have an amazing day.
Thank you so much, Dr. Emeka. Wonderful speech. Last on my call is Dr. Chris Otigbo, the Chief Medical Director of St. Clair's Specialist Clinic, Surulere. You're welcome, sir. Quick remarks, sir. Thank you very much, sir.
How are you? Good afternoon, everybody. I'm really happy to be here, primarily because I've been involved with this disease for well over 3 decades, starting from my postgraduate days in medicine. But most importantly, because this advocacy group is second to none in this job you're doing. And how I wish other NGOs had this pattern of outreach for the benefit of all who are involved. It's rather unfortunate, like the first speaker said, that outside Lagos state government, there's really no government input into the affairs of sickle cell disease. It's really, really unfortunate. And I think I would encourage all such advocacy groups, not all those set up for pecuniary reasons, to do more in getting government functionaries on board. The second thing is also to get many more doctors in general practice to get involved. Now, these chaps are really handicapped because the medical schools in this country that should highlight sickle cell education and management among sickle cell patients have failed to do the needful. And this, my younger colleagues or other colleagues, see sickle cell as just pain, which is far much more than that. From what the lady in US told us, you could see that it's a lot more than that. And the mental health aspect of sickle cell is gradually coming in the forefront. And it is peculiar in the sense that pain here is recurrent, most unlike other situations where you have pain. And we have to be mindful of bogus pain, which is now the anathema for going into drug abuse. But please, let's have more of this. As long as I'm on my feet, I will be here. I will encourage you, and I'll listen out to whoever wants to get in touch with me. I guess the director has my particulars. I'll take numbers from any, whether interested parties with or without. I think I want to share my little knowledge with you. Thank you for coming here, and thank you for inviting me.
Thank you so much, sir. So much wealth of wisdom. So please, let's connect and let's collect. All right. So I want to also recognize Isirino. Mr. Isirino is the ED of Next Gen Initiative. Please clap your hands for him. He's here too. All right. So right now we're about to enter into the last phase of this this course, which is the panel discussion. But to set the stage, I'm going to welcome Dr. Adeshola. She's going to come and just give us an overview of pain management research in Nigeria for 5 minutes. Then we'll bring up the MC for that session and the moderator. Let's welcome Dr. Adeshola from Exin Research Limited. Clap your hands for her to set the stage for the discussion.
Good afternoon, everyone. All protocols duly observed. Please, let's wake up. A lot of us have been sleeping, but it's fine. You know, when I was giving this presentation to do, I was told to handle a review of pain management in Nigeria. And I got here and Dr. Ogundikpe presented, and I sent a message to Mr. Toby that please don't project my slide. Looks like I copied Dr. Ogundikpe. I couldn't have said it any better. Okay, so the angle with which I'll be talking about pain management in Nigeria is from the angle of clinical research. I just want to say that before you see any drug marketed out there, a form of research has been done. True or false? Now, in my experience with research, where I worked remotely with a site in the US, we worked on medications that basically were given to Caucasian women, Asian women, less of African women. And at the end of the day, when these drugs are approved, they'll be shipped here and we'll be taking those medications. Do you know we're different? Apart from the fact that genetically we're different in the ways our bodies process these drugs, it is actually very different. There's a reason why doctors in the house, you know, more recently they said for antihypertensives, there's a class you give to Africans, right? There's a class you give to Caucasians, right? Then why is it that when we want to do clinical research for drugs pertaining to patients with sickle cell disease, most of the persons that use this medication are not Africans, specifically not usually Nigerians? And this is where we have the highest burden of the disease. So every day when I wake up, I say, thank God I'm alive and thank you for Exin, because Exin Research, the premier clinical research organization here in Nigeria, is currently conducting 5 studies centered on sickle cell patients. And in one of the studies that I'm involved in, now, when this medication goes out there, it will reduce the frequency of vaso-occlusive crisis, the #1 cause of sickle cell pain crisis among sickle cell disease patients. I am so proud and happy to be a part of that. So what I am trying to say, or what I really want you to know is I'm appealing our doctors in the house, please let us get involved with clinical research. Let us encourage our patients to engage in this research. We can get more and more medications that would help in alleviating this pain. You want to reduce the pain burden in Nigeria, you need to go into research. Yes, you will give medication. Yes, you will be empathetic. Yes, you will create support groups, but we need better drugs. And this is not possible if we do not partake. So that will be my brief review of pain management in Nigeria. Thank you.
Wow, thank you so much. It came out of our spirit, All right, so to initiate the process for this session, I'm going to welcome Mrs. Sheila Ojei to come and introduce the panelists as we set up the stage. Then if you have questions, I think we will add Dr. Ogundikpe to the panelists. So in case you have any question, we just add everything together. So Ms. Sheila, you can just come and call up the panelists while we set up the stage. Thank you, ma'am. You're welcome. Please give a hand of applause.
Good afternoon, everyone. So this is an interesting honor. First of all, I would like to commend everyone for being here today. I am an advocate, I am a friend, and just listening to the experiences and also listening to everyone's, story, as well as getting to learn things that on a normal day I wouldn't have known. So it's truly an honor to be here. And for every warrior in the house, you are the strongest people that I know. So I have the honor of introducing the panel for the roundtable discussion. And I will start with just introducing the moderator. So Toyin Adeshola, where is, there she is. Can we all please, round of applause for Toyin Adeshola. As she comes forward, I would also like to invite Dr. Funto Kalejaye. Please, a round of applause for Dr. Funto Kalejaye. Also, Dr. Lawrence Enokekwa. He's joining online, and I really hope I have not destroyed your name, sir. Dr. Lawrence Enokekwa, who is going to be joining us online. And Dr. Bodunri Osikomaya. Hey, I've destroyed that name. I know I have. I know deep down, I know I have destroyed. But Dr. Bodunri is also joining us. Please, a round of applause for Dr. Bodunri. Let's also welcome Mr. Peter Oshikoya. And Ms. Ibukun Ajayi. There she is. And finally, let's welcome Dr. Niyi Ogundipe. Okay, so I am now going to hand over to Toyin over here.
Okay, thank you very much, Sheila. We're going to make this fast because I know a lot of us are like tired, but I decided that this is an important aspect where we not only hear from the point of view of medical doctors, but from the point of view of people living with sickle cell. It's very important that we understand their own perspective, and as well as us as sickle cell warriors, understanding doctors' perspective and the challenges they are faced with. So that's why we're going to have this discourse. And it's a panel, it's a round table. So the thing is supposed to be interactive. I know I hold the mic to moderate this event, but I want to make it as interactive as possible. So there's an opportunity to share your comments and all that. So my first question will be to Ibuku. Okay, we're talking sickle cell now. You've been living with sickle cell for so long now. But from your perspective, what has been your experience managing sickle cell, especially in Nigeria, when it comes to pain management?
Hi, everyone. Okay, so my name is Ibukun, but most people know me as the Imabong on social media, so don't get confused. I'm the same person. My perception with pain in Nigeria, well, it's okay.
Try.
So I think I would use my last surgery in Igbobi as an example. I was there for a skin graft, and I remember battling with the nurses for to allow me to take my pain meds when I'm like, even when it's not time. So they time you, they say, okay, every 6 hours. But the truth is our human body is not the way. You can't basically plan it and say, okay, 6 hours is when the next pain is going to start, and I had to battle with my doctors, and they had to wake up a doctor at 3 a.m. I remember very well, to come and prescribe the pain medication for me, because the nurses said, as long as the doctor doesn't write it, they're not going to prescribe, they're not going to administer. And I'm just like, it's a different experience here, because I've also had out of the country experience in the US and the UK, and they basically ask you, what's your pain level? And when I'm there, my family there, they say, don't use your Niger standard here. Do you understand? They'll tell you, like, basically, if it's 9, say 9. If it's 10, say 10. Because in Nigeria, if it's 10, you're saying it's like 5, So they don't think that maybe you're just trying to grab the medication from their hand. But over there, they're like, just tell us how exactly you're feeling right now, because I think the understanding is a bit better over there than over here. And even when I'm having discussions with my doctors, they'll tell you, they are trying to be careful because there are so many, and I'm like, if I'm coming to you to a hospital, it means my pain is serious. Do you know that I can actually get these drugs over the counter if I wanted to? Because the truth is, we're not so strict when it comes to medication in Nigeria. You can even take a fake whatever and go to, in fact, all I need to do is take the empty medication tablets that maybe I was prescribed in the hospital to my pharmacy and say, oh, but they prescribed it for me in the hospital, and they will sell it to me.
Yeah.
Do you understand? So it's not so hard. So if I'm in the hospital doing the right thing, talking to you, then I think you should regard my pain.
Yeah. She said something, which is where I'm going to come to Dr. Kalejaye, because you're somebody who is in the field. And when I mean field, you see sickle cell warriors on a regular basis. And she said something about asking about pain score. Now, in all the hospitals I've been to, I've never, there's only one, I'm not going to mention name for advertisement purposes, before they say we're promoting them. There's only one that they actually asked me, and for a while I had to think, because asking you that question makes you really think, okay, what level of your pain is this? So how can we manage a situation where you ask those questions, especially in public hospitals where you are surrounded by multitude of cases? And as a hepatologist, not only hematology you're teaching, sickle cell you're treating. Yeah.
Thanks for your question, and thank you for having me here. So a lot of people living with sickle cell would come to the emergency rooms, usually with acute painful episodes. And please note that the reason they have come is because this pain has not been proper. They cannot manage the pain at home by themselves. As a routine man, we ask what your pain score is, and we explain. I'm sure you can agree with me, Dr. Alagbada. Oh, yes. So we tell you pain, 0 score, no pain at all, okay? Now on a score of 0 to 10, can you tell me, 0 being no pain at all and 10 being most severe, can you tell me what your pain score is, or how severe is this pain? And more often than not, they tell us what it is. And that kind of guides us into what medications we should give. I don't know if I've answered your question sufficiently.
Yes. Yeah, technically.
Please come.
Okay, I want to say something. Before I even speak, I'd like to recognize Dr. Lawson, who is online. Let's give him a round of applause for taking time all the way from US to be with us. He's a medical doctor and living with sickle cell. So he has those two perspectives. But following up from what you said, that you ask it. But I'll put Dr. Oshikoya on the spot, and and ask you that, is every hospital practicing this? If not, why?
Thank you very much for that question. I can't answer that question because I don't work in every hospital. but the training is for you to ask what is wrong, how painful it is. Can you describe your pain? Using that word pain score can be the little bit of difference, but most doctors are beginning to ask that how painful it is from 0 to 10. I know that we don't usually use the facial expression for it, but we do try to ask that what is your pain score, and we try to work on it. However, from my own experience, I've had quite a number of my friends and warriors trying to exaggerate the pain so that we could have the medications regularly. I've tried to ask some of them why, and they'll tell you, as you said, the response to pain is different. Some people will have the peak and the peak of the effect of the medication coming up shorter than other people. So in a way, they try to exaggerate so that we can have more frequent pain medications. And that is because we, the healthcare givers, we always want to work on a protocol. We have forgotten that we should manage each person as an individual and not as a protocol. Thank you.
Thank you so much for that. I'd like to put this question to Dr. Lawrence. They've talked about protocol, but I know I'm sure your experience in US is different from Africa in general. And how would you relate what you've experienced, both as a doctor and as a warrior, to the impact of emergency, let's call it emergency or actionable steps when it's regarding to sickle cell? I hope you understood my question.
I believe I did, and thank you all for having me. I'd say that my experience in the United States has been quite unique, especially in the sense that I am now a practitioner. But before, as a patient, whenever I would go to the emergency department for care, it would be after a point where I've tried to manage things at home and were just unsuccessful in doing so. And so I think that in the United States, the healthcare system here, although it is comprehensive, it still has its shortcomings, and especially with pain, even just like in Nigeria, I think, many practitioners can also start to think of patients coming in for pain management as drug seeking, right? And so I think that because of the subjective nature of pain management at times, even though there are protocols that have been put in place, it is still up to the practitioner themselves to administer those pain medications and to truly believe the patient. And so now that I am a practitioner in emergency medicine, I definitely get to see both sides of that coin and can advocate for different patients. But I think the biggest thing overall is truly, believing the patient themselves, especially, when we're asking them, hey, on a scale of 1 to 10 or 0 to 10, what would you say your pain is? Believing their pain and then trying to administer those pain medications as quickly as possible. I know that, again, the resources may not be as extensive as they are in the Western world, but with these pain crises, it's truly a matter of treating someone humanely and making sure that they are at the very least being able to be comfortable in order to get through this pain crisis that they're going through. Because at the end of the day, no one wants to go to the hospital and be subjected to being berated or being told that their symptoms are false. And so I think that, again, treating the patient based on their what they tell you and their degree of pain is the key. And I hope that answers the question. I may have deviated a little bit.
Yes, thank you so much, Dr. Lawrence. Now, Peter, I'm going to address something to you. He mentioned trust. In your experience, going to medical hospitals, how do you make your medical practitioner believe you? How do you build that trust? Because for me, let me give you an example. If you're in a hospital, maybe a private, I think it might be easier in a private hospital when you see one person on a regular basis over time. But in a public hospital, you see, you might come today, see this doctor. Next time they bring you a totally different doctor. So how do you build that trust?
Okay, well, how do we build that trust? Okay, so for me personally, before I go to beneficiaries that I manage, for me personally, I go to the hospital with the aim of, I want to engage my doctor, right? Because at my level now, I think I've learned a lot about sickle cell. I remember going to last one day. Yes, prior to this, I hardly go to the hospital. Yes, me, I don't like hospital. I'm an advocate, I teach you to go to the hospital, right? Yes, I teach you, of course, I tell people I teach you to go to the hospital. And I came into the hospital, I was not feeling fine. I just collected, my dad just sends me money. I just told my auntie, please, I'm not feeling fine. I'm coming, I'm going to Lasut. I got there, doctor said, are you sure you live with sickle cell? I said, yes. Are you in pain? I said, yes. Are you came alone? I said, yes. Are you sure you're in pain? Are you registered to? I said, yes, I'm registered. And I came alone now because I know that I will not be admitted. Me, I was expecting not to be admitted because the pain was mild. I got there, they checked this and they said, we are sorry, you have to be on observation. After I interacted, because I interacted with them, that this pain is doing me this. I used to break down my explanation because I meet some doctors, their knowledge of sickle cell is vague, so I have to explain. And the doctor said, okay, based on your explanation, you take Akupan. Like, which one is Akupan? I asked question, what is Akupan? He said it's a pain relief better than pentazocine. I said, okay. And I was put on observation. Inside the pain, I went to buy all the drugs myself and brought it and called my friend, please come. Bring this, and this. Have you eaten? Yes. And I was giving Akupan. Like, it went to my vein. Like, my brain felt the pain of the injection, but I was relieved over time. So for me, trust that they will treat you well. But you meet some doctors, they want to treat you based on their knowledge. And that's where education comes in, right? I had met one doctor in the same last week, the emergency, was telling me, please, what's your problem? I need to go. And I'm like, okay, calm down. I'm not the other patients used to see. You will sit down and listen because it's your job to listen. Yes. It's just that we as patients, we don't have that courage. Again, we can't tell our doctors to be patient to listen because they believe you are teaching them their job. But it's my health that is at stake, not your own. So sometimes you make them understand the pain so that they treat you right. Let me not go forward too much.
I agree with you in that sense. I think a lot of times, and I was at Twitter space the other day, and a lot of us don't know that there's a patient rights bill. You have a right to ask. Nobody knows. The doctors don't know. The patient doesn't know. So I had an issue. I said, so you have this bill. How are you educating people with it? But that's another issue to discuss. So I'm going to come to Dr. Ogudikpe and continuing on my question, trust, but from a doctor's point of view, how do you engage trust from your patients?
That's a tough one. But, I think basically so I think basically the patient comes to the hospital with the belief that and the trust that he will get medical care and a good medical care there. And so the patient coming shows trust. That's number one. Number two is the doctor responding appropriately. Like the last speaker said something about people not understanding the illness. Yeah, it will be difficult to dispute that assertion. And the problem being that in our wrong methodology of teaching, or in a culture that we have somehow inculcated. You know, I'm sorry to say this, it's like the country is always on the survival mode. How do I live to face tomorrow? How do I live to face tomorrow? And so living to face tomorrow is number one. And then the issue of the pain gets relegated to the background, in the sense that, oh, what is his problem? Pain. So we tend to, I'm looking for the one that is gasping, I'm looking for the one that is this, I'm looking for the one that needs surgery, I'm looking for the, so and then there is an issue of shortage of staff and a lot of things. So we are to blame to some extent. Like I said during my lecture, that we also have not fully optimized the usage of the personnel on ground. And I sometimes one of the reasons being that we have not properly educated them. I've told you about a registrar telling me some things, and I'm an anesthetist. I work with doctors. I work with surgeons a lot. It's always a war, right? I didn't know, maybe that was my formative. I didn't know I was tending towards pain until the surgeon made fun of me. You always be saying, yeah, patient must not feel pain, patient must not feel pain. So to that day, I actually say that in a lot. Patient must not feel pain, patient must not feel pain, patient must not feel pain. And but people say, oh, once we can do this even surgical, once you can do the surgery, patient survive and go to the, we've done our best. I mean, that's the best we can do. So that's the, so to build trust from our own point of view, a doctor has to understand his duty. Right. Also know that it is your duty to keep abreast of information, of medical trend, to be properly informed. I think I was here, I told them about, if you don't know a particular dose, check it up, okay? You can't claim ignorance. Let me give you an example. While still preparing for my lecture, I was checking some things online while sitting down there. I mean, I'm not supposed to know it, but I'm supposed to understand gaps in knowledge and take steps to adequately fill it up. That is what the whole thing is all about. Because tomorrow, the rules could be reversed, and we have to understand that one. A doctor died sometimes ago because nobody could do CPR. And I was like, look, if as a doctor, you are in the midst of people who cannot do CPR, then you are in trouble. I mean, yes, it could be anybody. Yeah, and it could also be you. So as medical personnel, let us understand gaps in knowledge. Sickle cell is not like a beta, it's not a syndrome of, it's not like cystic fibrosis, it's not like beta, it's not something esoteric. We live with it. We see it every day. And if it's that the only thing we are going to know very well, we should be able to know it very, 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 very well. On the issue of the trust about pain, like I said, I will explain to the person what I'm going to do with that score, because that is very, very important. Look, I need your score to be decided. It is that score that I'm going to use to treat you and monitor you. I don't want to prescribe wrong drugs to you because they are bad. I also don't want to under-prescribe to you. So help me to help you. They will understand, then they will communicate, then they will explain better. I see a lot of patients with chronic pain. Maybe that's how I'll be able to develop my own. People come over and you have to just go through those things. Thank you. I hope I've tried to.
Yes, thank you. All right, so I'm going to put this question to Ibukun. Now, you know, as sickle cell warriors, I mean, when we had the speaker before talk about the emotional and psychological challenges. Now, living with sickle cell and experiencing the pain of sickle cell, how has that hampered your productivity? And what steps do you normally take, when you're feeling, in that space, but you got to do what you got to do?
This is a very important question. But sorry, before I delve into this, I want to add something to what has been said already. And one thing I want to say is medical practitioners should help us to help them, because sometimes you step into a hospital and once you start talking about I'm feeling pain, the next thing you hear is you people have come again, you warriors have come again. Unatu, like, you hear that generalization and I'm like, I don't understand. Who is you people? why are you referring to me as like, I am my own person. I have my own pain charts. I have my own type of crisis. And the funny thing is they assume that we all have the same type of pain, but it's not true. Just the same way we don't have the same kind of, what's it called now? Illnesses. Some people have leg ulcers, some people have bone crisis, some people have AVN. Do you understand? Some people have all of it. But we usually don't have the same kind of complications here. That's what I was looking for. So don't group me and say, oh, you people have come again. And then another thing I think will help with the whole idea of what's it called, drug abuse and pain medication abuse is the fact that when you're prescribing a pain med to a patient, kindly tell them the side effects, the adverse effects of these pain medications. Because when I had my first epidural surgery, I wasn't told the adverse effects of epidural. When I had epidural, I was happy, oh, I'm not going to feel pain. It was after doing it the second time in the US. If I was when I was about to undergo, the doctors there told me, okay, these and these are the side effects of this epidural that you're about to undergo. And I've had it 3 times after that. And I'm like, okay, so if I didn't know the kind of pain I was going to experience, the kind of backaches and things I was going to experience after that, I had no idea. So I feel like if people know the side effects of these drugs that you're giving them, it will be at the back of their mind that I don't think this is a drug I want to abuse. I don't think this is a drug I want to take even when I'm not feeling up to that pain level that requires that I take this drug. Because the truth is you're ruining your own life at the end of the day. And we already have enough complications to deal with and to start adding all these other extra things to it. So I think medical professionals should tell us adverse effects of medications when they're, especially when it's a new drug you're prescribing to somebody, so that they know. And then they are left to the decision. Then to your question, sorry, I had to sidetrack a bit. The emotional and, mental, to be honest, especially when it comes to my work, because as a person who has sickle cell, some of us may have experienced workplace stigmatization. So that's an issue already, If I would say if someone who doesn't have sickle cell should call into the office, and say, oh, I need a day off. The idea is, oh, they just need a day off. If I am someone with sickle cell and they know that I have sickle cell, calls into the office and say, I need a day off, their mind has gone to 500 million places before. They're already thinking, is she dying? Is she going to die tomorrow? What's happening? Does she have a stroke? As in, their mind has gone so many places. So sometimes you're physically and mentally not able to carry out, your duties, but you just have to try. You just have to put yourself down and cope. And I remember at my last job, the last article I wrote, I think was, it's okay to say, I'm not fine today. And I think my boss got the idea and he gave us a week off after that, because I'm like, I just can't take this anymore. I am under so much pressure and I cannot bring myself to say, oh, I need time off, because I already know where your head is going to go to. So it's difficult, but I think one thing I do for myself is, people that know me, I love to do things that make me happy. So I might have a horrible day at work and then I'll just buy myself suya or ice cream, or like out of the blue, just do something fun for me. Do you understand? Something that would take my mind off all of the anxiety and the stress, because the truth is, like somebody said earlier, we forget to live and we focus so much on the pain, on the struggle, on the wahala. I'm also an influencer. I can be this tired, but I will dress up and go for a movie premiere because I need to get my mind off the stress that I'm going through right now. So those are the little things I do for myself. I just try to make myself happy in the midst of all of the madness. And then once in a while, I speak to someone. I know that sometimes we feel like people may not understand where we're coming from. Even people that are living with us sometimes don't even get it, but I feel like sometimes just offloading to a random stranger can help. Just offload, like take everything off your mind and breathe. It helps, honestly. So that's what I do. Thank you.
Thank you so much. Wow. I'm going to take this question to Dr. Lawrence. Now, you Lawson, sorry. My bad. I'm so sorry. She talked about her experiences, but I want to look at it from your own landscape. How was it with you growing up, especially when it comes to family? How supportive was family? Because I see there's a trifold. We always look at, the doctors, and we forget the family, how the family makes us feel, when we're even complaining that we're not feeling well. Because I know some of us even hide the fact that we're in pain from family because of the perception they live out. So how was it with you?
Yeah, so both of my parents were very supportive in my journey as a patient with sickle cell. And I'm not sure if it's been established, but I actually have hemoglobin SS, sickle cell disease. So, as a child, I was definitely having plenty of hospital visits and going to the hospital for frequent sickle cell crises. And then it wasn't until I was actually placed on hydroxyurea that, the frequency of my sickle cell crises decreased dramatically. But I'd say that with my parents, my immediate family, they were truly crucial in getting me to where I am. My mom is a registered nurse. She works in the neonatal intensive care unit. And so she, had a understanding of the healthcare system, especially here in America. And she would truly be my guardian whenever I would, go into the hospital looking for care after we were unable to manage a crisis at home. And so, there were definitely instances in which I would have to wait for hours on end in the emergency department, even in the Western world. There were times where, they would deny me certain pain medications after a certain point, or not even believe that I was in pain. And so, those instances were tough for me, but knowing that I had my mom, who was my strongest advocate, including my dad as well, it definitely helped to make sure that I was given adequate care, and that, I wasn't subjected to these instances as frequently as it could happen to other patients. And so, as someone who's, again, gone through the process of going to medical school and finally being able to practice, I've been able to take care of other sickle cell patients. And I see that a lot of them don't necessarily have the support of both of their parents in order to take care of them or advocate on their behalf while they're in pain. And so I do definitely think that, family in this case, and in the case of other sickle cell patients, can truly make or break the prognosis for sickle cell patients, because their support can truly mean the difference between a good outcome and a bad outcome.
Thank you so much. I just want to ask one last question before we throw the floor open, and it's for Dr. Oshikomaye. When it comes to blood, because we find that as, I don't know, I'm sure maybe Lawson doesn't have that challenge as in the US as much as we have in Nigeria when it comes to getting blood. How impactful is it in managing pain, and what can we do to able to break that stigma when it comes concerning giving blood?
Thank you very much. First, I must say that pain is pain, and the need for blood is different from pain. There are studies that have said that adequate transfusion will prevent vaso-occlusive crisis. All sorts comes up. Blood can help with extreme blood transfusion too, and then it will reduce the pain because it will help to remove the sickled cells. So the role of blood transfusion and pain is there. Studies have said is controversial because sometimes the damage, it's not just red cells that cause the pain. We have the white cells, we have a lot of chemical agents, a lot of things happen. So blood is blood. The need for blood is for anemic cases, for prevention of complications. And then the pain itself could be due to other things. And the most common is due to vaso-occlusive crisis. Now, coming about the stigmatization, the stigma with blood, giving blood. Well, we need to do a lot of advocacy. Many warrior-based or sickle cell-based groups work with us, and we do a lot of advocacy. Unfortunately, it seems to me that it is the relatives of our warriors that are reluctant to give blood. When I try to know why, direct relatives, some of them are AS, and they feel that with AS they can't give blood. Some of them are afraid because in our community we do a lot of replacement blood donation, so they want to keep the blood until their relative needs blood, because when they get to the hospital, people tell them go and donate blood. So we have been able to we know this already. So I need to actually commend IMA Health Initiative or IMA Health International for what they do. They wrote proposals, they have this particular project whereby they give blood to people living with sickle cell disease, warriors, at the same cost as blood given at the government hospital. So all you have to do is to go into their platform. On their platform, that's their app. Get it? They would have expected you to have had a grouping from the hospital. You put the group on the platform. The blood is collected from the Lagos State Blood Transfusion Service at the cost of 7,000 screening fee. I know that the recipient will need to pay for the blood, but you do not pay for the logistics. So wherever you are, they'll get the blood there for you. The only way we can help out is to ensure that no extra costs comes from it. And they have done a very good thing. Unfortunately, we still have complaints. The blood is there. We have a pool of blood ready for this particular project. And I keep asking her, please, we have 10 units of blood kept for you for today. How come only 2 people have picked? I know that many people do need blood. And the thing is, people do not really know of this particular initiative. So let us try to see what happens. And there are many other people. I was just talking about LifeBank's boats projects. So LifeBank has a lifeboat project, like 1 boat. Yeah. So this particular boat project, they also work with us. They work with Lutz and many other private blood banks. But the good thing is that you don't even need to pay for the blood. So they have this pool of money donated by corporate organizations or NGOs, grants. But the thing is, your managing physician needs to apply to request for the blood. And it has to be that you are unable to afford the blood. So when you request for this blood, goes on the platform, they will look for the blood and they will deliver the blood to you wherever you are. So blood availability is quite low, we know, but there are people that are doing their best, make sure it's available. People don't want to give blood, especially amongst our circle, because they want to keep the blood for dialysis when they need blood. But we don't need to wait within this circle to give blood. There are many people that love to give blood, and numbers of voluntary donors are increasing every day. And especially in the corporate world, we just sell it out as a CSR. Companies want to do CSR because they don't want to pay tax. So we try to do what? We just capitalize on it. Or they want to pay reduced tax. See, guys, it's a CSR. It gives you a very good picture in the world, in the what you call the community, in the international world. Do it. And we had things like this. We make sure that people, organizations like IMA Health have blood for this. We give it to sickle cell people. There are many people that we give blood out to that do not pay us. And the numbers are increasing. We cannot say no to somebody that needs blood. If you are coming to the Lagos State Blood Transfusion Service, the number of people that cannot afford to pay blood is increasing. The economy is not smiling, I have to say. Inflation rates are going and things are becoming more expensive. So we have to do our best to keep you and I alive. So there is light at the end of the tunnel. There is light at the end of the tunnel, and I know that things will get better. Thank you very much.
Thank you very much, Dr. Oshikomaye. Thank you so much. The Executive Secretary, Lagos State Blood Transfusion Service. I know you have to already leave, but if you can wait to take a few questions, if not, we give you the grace to take your leave. But so this is where I leave the floor open. Okay, you wanted to comment on something?
Yes, Dr. Lawrence, thank you very much for your contribution. Dr. Lawson, I'm so sorry. Thank you very much for your contribution and your wealth of experience. In our center, we, when a patient comes in through emergency, we actually train to believe that person's level of pain, and we go ahead and treat accordingly. So thank you for addressing that point. You also talked about your family support, which is something I think we really need to work on in this part of the country. I'll tell you of a rather uncomfortable situation I saw in one of my sickle cell clinics. as best as possible, when people living with sickle cell come to our clinics, we try to educate the parents as well. So it's not just medical, it's also psychological. And then we also have a group of specialists that work with us, and we can actually refer them to the appropriate specialists, because management of sickle cell disease is actually multidisciplinary, and we have to understand that. So this lady walks in, she's actually a trained nurse, and she brings her son, who's about 18 years old, and she goes, I'm tired of this child. Each time I make a little money, he decides to fall ill. And the little money that I make, oh yes, little money that I make, I have to spend on him. So what I've decided to do is to prevent these painful episodes and give pentazocine. And guess what? The child becomes hooked on it. I had never heard of that kind of situation before. And I realized that sickle cell disease is just beyond the person that lives with it. There has to be a lot of education where the parents are concerned as well. Now, this kind of a boy, we had to be multidisciplinary. We had to go through the psychologist and then the drug dependency unit of the psychiatric unit. We had to explain, you're not going to psychiatry because you're mental, far from it, because that's the belief of many patients. I'm not going anywhere because I'm not mental. But we have different subspecialties within psychiatry, and we know exactly where you need to go to. So this patient had to be, managed by quite a lot of us, at that point in time. But I do realize that family support is of utmost importance.
Thank you so much, Dr. Kalejai. Okay, so anybody comments, questions? Okay, I'm going to take, wow. Yeah, okay, Dr. Chris, David, and Dr. Shola. Jade, sorry. See me, my names. So Dr. Chris first. Can someone pass him the mic? Thank you.
Yeah, thank you very much. In line with the comment I made earlier on, trust is engendered by the doubt. Like I said earlier on, we are the problem in this country. An average trained Nigerian physician should rise above the knowledge of a Western trained physician in sickle cell disease, but it's not so. Now, when you talk about trust, let us remove from our minds, it's a phantom pain. But somebody you've not met for the first time, give him the benefit of the doubt. You cannot talk about phantom pain if you're not used to the patient. It takes much more knowledge than looking at the face, whether there's, whether there are some facial exchanges or whatever. It's not right. Give the patient the benefit of the doubt and do what you have to do. Secondly, don't limit yourself to pentazocine, penta. It's becoming a problem because out there you have all sorts of pentazocine. Out there, all sorts. There is a broad spectrum of analgesics, and for as long as you go from one to the other now and again, the issue of getting hooked to it is reduced to the barest minimum. It is. Last but not the least is, if we as physicians can inculcate one knowledge I gathered so long ago, that it is criminal to leave your patient in pain, then you must do everything within your powers to abort the pain. You must. Last pain symposium I attended, there was an anesthetist there, orthopedic surgeons, mental health physicians. It was a big thing. And we shared perspectives. And then, last but not least, please remove from your mind that all pain is due to vaso-occlusive crisis. Thank you.
Thank you so much, Dr. Chris. Wow, that's so it's important that we look at pain in different lights. And I want to buttress the point on the fact that it's not only pains. Even in my later, let me say, older age, I found that other things have been working for me when it comes to crisis. It's only when the pain is reached that it's high, then I now enter the pain. And when I now tell you it's high, I want you to believe me, it's high because I know the one I'll be managing at home. So David, quickly.
Good afternoon, everybody. Doctor has already said part of what I wanted to say, but again, I would like to speak on behalf of the doctors. I'm not a doctor, I'm also a warrior, but I belong to a few sickle cell groups on WhatsApp, and whenever we talk about this pain issue, they're always blasting doctors. Doctors are not your family members. You need to, before you can gain trust, you need to have a relationship with somebody. Exactly. So you have a particular hospital today, tomorrow you're in another hospital, the next day you're in the third hospital, and in a year you're in 6 hospitals. How do you gain trust? So I think the warriors need to talk to themselves first. Do you trust yourself to stay with one person or to stay with one hospital? It doesn't make sense. We all know that pens is, personally, I try as much as possible not to be administered that stuff because I don't want to get anything that will get me close to being addicted. I don't want it. A sachet of paracetamol, I can tell you this year, I don't think I've taken up to 2. Not because I don't have pains. Not because I don't have pains. As at yesterday, he's a witness. He actually wanted me to be his PA today. And I said, no, I wouldn't be able to do that. I've been down for the past 3 weeks. I just came out today. But if I don't tell you, you wouldn't know. What do I do personally? Personally, what I do, it may not work for other people. I take plenty of water. And it helps me a lot. I had a crisis in the last 3 weeks. And I didn't step out of my house. All I did was that between 12, of course, we know the unwanted visitor comes midnight. I started taking water. I took about 6 sachets of water between 12 midnight and 5 a.m. And I didn't mind going to pee regularly. In January, I hardly fall sick, to the glory of God. My own issue is just Lagos, on and off, on and off, on and off. In January, I fell ill. I went to Ibadan. I'm a photographer by profession, and then after the festive period, I decided that if I don't want to break down, leave Lagos and go elsewhere. So I went to Ibadan, and that was where I broke down, what I was trying to avoid. I had crisis there, and of course, like I said, this is a hospital I've not been to in Ibadan. But I had to gain trust with the hospital, with the doctors, and I made them understand that, look, I was messed up, but I knew I needed to use this pen. And I know these people, because they don't know my history at almost 40, I know nothing scares me anymore. They can easily come because of the way they've seen me, they can decide to start pumping pens into me. I made them understand, no, let me know how many, what do you call that stuff now? Sir? How many arms you are going to pump into me? At the end of the day, I was there for about 5 days. I got only 1. Not because I was not in pain. But at the end of the day, when you get addicted to these things, if I go there tomorrow, the doctor will understand that when I come and I tell you the pain I have is 9/10. It won't take me on seriously, so to say. Then one more thing, Anthony, please indulge me.
Okay, make it snappy, make it snappy. We say one more.
One more thing.
To ask Doctor.
Okay.
Go ahead.
All right. So one more thing, I just want to encourage our people. The issue of taking drugs, like I said, please don't do what I'm doing. That's what works for me. I decided long ago that I don't want to rely on, I know we live on drugs, but I don't want to rely as much as possible. Like I said, I've been ill in the last 3 weeks. I've only taken malaria drug and paracetamol. All I'm trying to say, as warriors, I know we have a few of us here. Let us have relationship first. You can't just barge into somebody and say you want the person to trust you. Do you trust the person? Thank you.
Lovely insights. Lovely. Can I contribute?
Hello, everyone. Again, good afternoon, Chief. Good afternoon, everybody. So I trained in Luth, and I have Dr. Adeyemo here who taught me hematology in 300 level. Thank you. And as a house officer, my introduction to medicine, to practice, was in Dr. Kyle Ajayi's clinic, where most of our patients were sickle cell disease, patients. And now I work at Exin Research, and I am on hematology and sickle cell disease projects. And that's really the core of my work. So this is very important to me in a lot of ways. The first patient that we lost, and I know you might not remember, his name was Tokumbo. And I've never forgotten, because he looked me straight in the eye and said, at the point he was dying, last breath, he said to me, I told you I was in pain. You didn't believe me. And I have never forgotten. I cannot forget. I cried. I left the clinic. I left. I don't know if you remember. I left. I went to the hostels and I couldn't come back for the day. And it stayed with me. It has stayed with me. I remember his mother's cries. I remember everything about that day. It was horrible. It is horrible. I have never forgotten. And here is why. I feel a little bit guilty. But it was what I knew to do that I did. And it was the protocol that I followed. And I forgot. Not like I forgot, but I didn't understand how important it is to be human before you are a doctor. In that moment, I didn't understand. Because I grew up on house. Medicine is my first love. I started watching the medical shows before anything else. And house would always tell you, patients lie. It's true. If you ever watch house, and everything is caused by lupus, those two things, that's what house taught me. Patients lie and everything is lupus until proven otherwise. It's not true. Patients can't lie. I have been lied to, lied against, lied for, lied whatever. But patients don't always lie. I've been a patient and I've had pain. I have 2 kids, both via cesarean. And I was opportune to see my case note. I had a terrible time with my second complications and all of that in the middle of COVID. And I was opportune to see my case note and they wrote no significant pain. And I was crying. My colleagues did that to me. I had that child where I was working. I've shared that with you. It was horrible. I'm never going to have another child, ever. It was too much pain. I'm done. Pain will cure you of your love of children sometimes. So as a doctor, I don't have sickle cell, so I can't even claim that I understand the depth of how painful it can be. But I'm a mother. I'm a woman. Women cannot always escape pain. If it's not your periods, it's pregnancy. If it's not, that is delivery. And so we're more in tune with the pain than some other people might be. Some of us. Some other people have a very easy time. I didn't have a very easy time. And my colleagues, my co-worker, wrote no significant pain. The nurse that was supposed to stagger my medication wasn't staggering it. I didn't want to make so much noise because I can be very, very particular. And I didn't want it to be that because I am now a patient and I work there, I was taking advantage. And so I was quiet until I couldn't be quiet anymore. And even then, my friend wrote no, and I can't forget because it was a lot of pain. I had complications afterwards. I couldn't stand, I couldn't walk. The wound reopened. It was nasty, it was bad. And they wrote, if they had listened, when I was saying this, I've had one cesarean before, this is another. That's not how it felt. This is bad. Like, this is terrible. And I can feel fluid here, and I can feel this, and I can feel this. And they still wrote no significant complaints. Like by me. And I saw it after the fact, and I had to call that doctor to order to say, you don't do that to people. I told you a different thing. You didn't call the consultant. You didn't say anything to anybody, and you wrote no significant pain because it's night duty. What is this? And the nurse on the ward, I had to report her to management because she told me, why are you being difficult? And I said, no, if this is what you've been doing to patients, you can't do this to me because I am telling you that you need to stagger my drugs, and because you want to put everything to one time so that you do everything and then you go and sleep, you're rushing all my medications. And if that's what they're doing to sickle cell disease patients who actually are in pain, it's not fair, it's not kind, it's not humane. So we need to be kinder to each other as human beings, treat people with decency. And that brings me to the question that I actually have.
Okay.
I have a question. Both to my trainers and my senior colleagues and everybody here. What is the role of placebos in the management of sickle cell disease patients, especially when you consider addiction or people at the risk of addiction, how do you triage that? How do you manage that? Because this young man who died, was really addicted to pencils in very complicated situation. And he was one of the most brilliant people I ever met at that time of my life. He was really smart, very funny. You know, it was just really sad. And I didn't really believe him.
Yeah.
That's the truth.
I think I'll put this question to Dr. Lawson. You know, she said a whole lot. And I think from your point of view as a warrior and as a medical doctor, what is the role, and then what will be the steps you feel will be adequate enough for you to feel treated with some form of dignity, if I will put it that way?
I just to make sure I'm getting the question correct, you were asking what the point of placebos in the management of sickle cell crises. So to my understanding, a placebo is no treatment at all. And so, you know, it's a false, we're going to give you a medication, so to speak, but it's one that has no clinical or pharmaceutical activity. And so if that's the case, and that's what we're referring to, I don't think it has any place in the treatment of sickle cell patients, period. I think that, you know, again, if someone is complaining of pain, to give them something that has no pharmacological effects is actually not, you know, taking care of their pain. And so I think that, you know, in doing something like that to a patient, it's actually not treating their pain as you should as a practitioner. So I don't believe it serves any use in treatment.
Thank you so much. So, but what would you feel are the adequate, just in two minutes or less, adequate steps that, okay, in treating this person from your own perspective, both as a medical practitioner and as a warrior?
So I think first and foremost, and this is backed by the American College of Emergency Physicians and the American Society of Hematology, their guidelines are to administer pain medications, be they opioids or non-steroidals, but some form of analgesia within the first 30 to 60 minutes of a patient coming to the emergency department or presenting in an acute pain crisis. And that's been shown to improve outcomes and reduce the risk of further complications of sickle cell disease. So, you know, first starting out with something like which can be a non-steroidal anti-inflammatory, such as ibuprofen, Toradol, and then, you know, reassessing the patient within the next 15 minutes or so after administering these pain medications and seeing how they're tolerating this. If they are still reporting that their pain is not under control or there's no reduction of their pain, then moving on to something stronger, such as our opioids. I think routinely in the United States, you know, morphine, oxycodone, Dilaudid, those are some of the medications that a lot of our patients are given. And if they have a pain regimen that has been certified by a hematologist, they try to follow that pain regimen. And then again, it's about reassessing the patient every 15 to 30 minutes, which can sometimes be tough in a busy hospital setting. But again, reassessing the patient, making sure that their pain is under control can further prevent any of the complications that are associated with sickle cell crises. In addition to these analgesics, adjuncts such as heat therapy, using heating packs or heating pads, hot water, warmth, things to hopefully induce vasodilation are truly, you know, very helpful in also preventing or helping with pain. And then also making sure that the patients are adequately hydrated, as one of the other speakers mentioned, even if it's orally or intravenously, making sure that they're hydrated in order to help with the effects of the sickle cell crisis in and of itself. And so again, it's all about pain management, making sure that they're adequately, you know, their pain is adequately being controlled. And if not, proceeding to, if necessary, transfusions, which, you know, is a crucial thing to have blood readily available. And I definitely implore everyone here to donate if you can, because blood sometimes can be the breaking point of a sickle cell crisis. Giving them this transfusion when all other modalities have failed is sometimes the necessary thing, again, to prevent these complications. So once again, starting with analgesics from the non-steroidal anti-inflammatories to paracetamol or acetaminophen, as it's called here in the United States, and then building up towards that opioids. And using adjuncts like heat therapy along with IV fluids, and if necessary, as the last line, transfusions. I'd say that's the adequate pain pathway, I believe. So,
thank you so much. I gather we have 2 questions. Okay,
right.
can we have the first person?
All right. Good afternoon, everyone.
Yeah. Good.
Okay. Thank you for the presentation, especially Dr. Nee. Okay, can everyone hear me? All right. Okay, I have 2 questions for you, sir. Okay, at what point should one refer or seek the attention of a specialist like an anesthetic, especially when managing a sickle cell anemic patient in VOC? And secondly, in preparing a cocktail for analgesia for a sickle cell anemic and patient in crisis, what is the place of time in the management of VOC?
Exactly.
In the management of what?
VOC.
VOC.
Yeah. Vaso-occlusive crisis.
Okay, VOC.
Thank you.
Okay, can we quickly have the second question, then we'll answer both at the same time. Who is the second person?
No.
Good afternoon, everyone. It's actually not a question, it's a comment in addition to what Dr. Ibukun said. Apart from telling a warrior the adverse effect of the drugs you are prescribing to that patient, I feel doctors should take their time also to educate us on the benefits of those drugs, the impacts those drugs will have on your health. Because somebody like me, sometimes I get tired, I'm a warrior, and I get tired of taking drugs. But the day a doctor sat me down and educated me on my drugs one after the other, I had a better understanding. And since then, I started taking them seriously. Thank you.
I agree on that one. The day I got educated on the need of folic acid is the day I changed my perception of folic acid, especially in Nigeria, and understanding why it's 5 milligrams and 5 micrograms outside. So I think you can answer those.
Well, thank you. I think I'll answer the first one. I'm an anesthesiologist. I don't particularly treat VOC, so I will dodge the second question and pass it to the consult hematologist. Now, referral to anesthetist. The present established pathway to get a patient to anesthetist, if it's not for operation, is for admission into ICU. Okay, we have not really established the pathway for pain control. Okay, there are very few. I think Ibadan has a pain and palliative unit. We just started one in the Gobi. Apart from that, anybody from Luth here? Yeah, any pain or palliative unit in Luth? Just starting. Lasuth? Anybody from Lasuth here? Pain and palliative there? No. General hospitals? No. So the problem actually is that if you have, there should be an established maybe like an understanding or arrangement with the anesthetist team before the patient arrives. So like, okay, this is how we're going to do it. Because number one problem is personnel. Okay. Let me tell you a story. I had to resign from my place of work and freelance for 3 years, all because I didn't want to enter the theater again. And I wanted to do payments. Do you get that? Because I like, this guy crazy. We need people in theater. we're going to open our faucet, we don't have anesthetists, blah, 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 blah. So many people are calling me. We need people still come, somebody still come and say, Lee, why are you doing yours? What's pain? Even my friends, anesthetists, UK trained, they're like, what are you doing? What are you doing, pain medicine? No, it's so boring. Just sit down and be listening to them. You know, the speech is therapeutic. I say, yes, you just be listening to them 1 hour. When I see a patient, I talk to them for 1 hour. I'm just starting. So you understand? So like, you just sit down and be talking, then they come back again. You see them the same. It's so boring. It's frustrating. I was like, I like it. You understand? So those two factors make anesthetists a bit scarce for them to push into pain. So there is not yet any established protocol because actually we have not even started at all. So if you have an anesthetist in your hospital, you have to sit down with him. Don't put any protocol. What can he offer? That's the most important thing because it's going to require personnel, time, and resources. And it depends on your level of training and what you can do. Aside my interest in pain, when I started doing nerve blocks, general anesthesia, ultrasound scan, guided nerve blocks, things like that. I did my part 2 project in pain, postoperative pain, also a lot of things like that. Then my interest developed. So over time, I had to train myself and increase my skill until I got to the level I am. Not so many people. I had to buy the ultrasound myself. So understand. So not many people will do that for them. So it's a scarce personnel with scarce skills and things like that. So call your anesthetists and tell them that we want to do this. What should we do? Fine, they can easily rush to surgery. They can rush to ICU. But pain, no. And you have to pray that the person has interest in pain or try and make him see the need. The demand for anesthetics is very high. And the first thing might be, I can't have pain to my work. But try and just explain to him and say, and just to give you a window. Don't demand too much initially. But I believe that once this person sees the help is rendering, the commitment will increase. Okay? Thank you very much.
So I'll take your time to treatment. So the ASHA, the NICE guidelines state that within 15 minutes of the patient's arrival to hospital, you should have triaged that patient. And by 30 minutes, you should have started your pain control management. 30 minutes on arrival, yes.
I think the main reason why I asked the question is that, okay, in the management of VOC, quite okay. It's not just analgesia you give to the patient. You also need to rehydrate. Okay, there's this patient I was managing. So I took the first step of giving painkiller as in giving an analgesic. Then I was rehydrating the patient, and I was kind of reassuring the patient that over time, once we address the issue of the blockage that to result to the vaso-occlusive crisis, it will get better over time. As well, administering the drug, that is the painkillers, rehydrating the patient. But it kind of occurred to me that a patient will want you that anytime he or she just shot for a pain issue, you're ready to give analgesia. You get so when is it necessary, or I think the place of time also have its own effect to try to explain to the patient that, okay, I just gave you diclofenac now. Why not allow so number of hours before I can give you another one? You understand? So that's it.
Okay, I think I can help him a bit there. In terms of medications. Now, what I would throw in that question with, what is the average timeline a medication kicks in?
So the medications actually differ. It depends on the medication.
Yeah.
The medications actually differ. The time of onset of action, the time they will pick, and then you have to know the dosage intervals, for example. Okay, so IV morphine within 5 minutes, 5 to 10 minutes, it more or less kicks in. Okay, pentazocine is even shorter, about 3 minutes, it starts to kick in. Oral morphine, on the other hand, about 20 to 39 minutes, it starts to kick in. So it just depends on when the drugs start to kick in. You want to know exactly when you expect it to peak. and what the duration of action of those drugs are, so you can stagger your medications. It's probably not wise for you to give all three at the same time and then have a point where a patient is analgesic free at some point and starts yelling for pain, for pain medication. But there's also room for breakthrough, analgesia for breakthrough pains, okay? Which you can also give at intervals for these patients, okay?
Okay, I think we've, is anybody, did I say anybody? No, okay. I think we've come to the end of this panel discourse. And officially come to the end of this event. I'll hand over to the MC, and I want to use this opportunity on behalf of our partners, Sickle Cell Health Initiative, Navana Initiative, and Exim Research Limited, and Sami for putting this event together, and all our speakers who came in the morning, who have stayed and spoken to us. I thank you so much. Lawson, thank you for waking up to speak to us and all the other speakers from US. I hand over to our able-bodied MC, which I'm sure he deserves a round of applause.
Thank you, ma'am. Before the MC speaks, yes, please, I would like to beg our doctors and nurses, please, if you're in private practice and you do that, you can't manage pain of sickle cell, please refer. Please refer, because it's affecting us in the field. Because you manage a pain for 5 days, the pain has not gone. You refer to a general hospital. Please, please. Yes, for our nurses in general hospital, please be empathetic. I used to fight. They know me last week. And Lutis fights, I used to come and fight. Now, a patient is in the hospital. You don't come and be saying things that are not good to the patient. And please also always engage the parents. Let them know what you are giving per time, because we have issues with they don't know what they are taking. And they ask questions. You are saying, don't worry, don't worry. No, please tell us what we are taking and tell us this is the time we need to take it. But honestly, please refer. Thank you.
A passionate appeal to every. All right. We appreciate all our online audience, and we're going to have just 2 more sections before we leave these premises. So just relax. You're going to be giving your certificates for those who partook in the pain masterclass. Then we're going to have a lovely ending. So let's welcome the convener of this meeting. But before we bring her up, we want to appreciate you once more for staying till now. Want to appreciate all the doctors, all the nurses. So to speak on behalf of the nurses, she's going to come up and speak because she's the convener, she's a nurse, she's a registered nurse in the US, and it's going to be very interesting to hear our own passion. Then after her, we'll have the vote of thanks, and we'll call up Mr. Bamdele to come and close us with the national anthem. So when we are done, network.
I'm so honored. I'm so thankful for every single soul that stopped by, both live and virtual. And I hope everybody has been able to get a new perspective and gain a new knowledge about effectively how we can coexist and co-admit or co-treat sickle cell crisis pain. Like I said before, this is a passion for me, not just because I'm a warrior myself, but also as a professional, as a nurse. I get to treat other people that have pain, and it's it gives me a different perspective to be empathetic and to, serve my patients in the way that I sometimes feel like I should be served, as, not only as a, a colleague, but also as just human being. And I appreciate everybody, especially my co-partners. They have been through this journey with me. It was just an idea I got from having to step in and advocate for people who would call me from Nigeria, and family members that would call me who have, family members in Nigeria who are in the care of any health providers, but are not getting the adequate attention to their pain. And I just thought, if I'm having all these calls coming in from very few people, I can imagine what other people are experiencing. So I figured, let's have a open dialogue, educate ourselves, make each other feel like human beings, and also remind healthcare providers to take a stand with the hope that you took. I know for nurses, we took the what? the Nightingale oath. And I know doctors as well took some oaths. So every time you go into treating your patient, just remember that. I know it's stressful. The job is stressful. It's very demanding physically, emotionally, everything. But once you step into your facility or your hospitals, I want you to leave whatever it is that you are feeling, and try not to, transfer that to your patient, because you can actually leave a lasting impression on your patient. And we want to make sure that we're treating our patients with the utmost respect and honor, and vice versa. And I want to encourage warriors to please, 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 please learn to advocate for yourself, learn about yourself, listen to your body. You're the best advocate that can be. The advocacy that I would give for myself would be different from somebody who come up to me and tell me that they need advocacy. But so I want to encourage us to be, to educate ourselves in our diagnosis, but also in learning about that. Don't make that your identity. You are much more than that diagnosis, okay? I, for one, I make sure I practice that. I know I can thrive, and I am thriving despite, okay? I used to be an accountant, went back to school and became a registered nurse. So you can do far more than you think. And I just want to encourage us and remind us to not live beyond just your diagnosis. And I hope everybody have been inspired. Thank you again for coming. I appreciate it. And I hope this won't be the last time that we come together. I hope we keep coming back and re-educating ourselves. And also people that have been here, please share the knowledge with your colleagues, with fellow warriors, with caregivers, so that we can impact the world and impact our communities. Once again, thank you so, so much. I appreciate it. Thank you.
Thank you, Bitayo. Thank you for making this a reality. Right now, let's welcome Dr. Fola Sade. I call that on purpose because there is no H in the name. Fola Sade Olubemi. See, I'm pronouncing your name now like an Indian. Let's welcome her. She gives a vote of thanks. She's from Exin Research Limited. You're welcome, ma'am. Then we will do us the honor of standing and closing this program officially with our national anthem, taken by Mr. Bamidele Oyewumi from Nirvana Initiative. You're welcome, ma'am.
Hi, everyone. This man is a Yoruba man, and he knows the difference between an S without a dot and the S that has a dot. Why is he doing this? My name is Fola Sade Olubemi Paul. I'm a medical doctor. I work with Exin Research again, and I am very, very glad to be here. This is very important to me. I feel like almost every one of us knows somebody who is living with sickle cell disease, even if you are not a warrior yourself. That's how common it is here. And so it's very unfortunate that we even have to be having some kinds of discussions in the first place. Like, this is something that, as Chief said earlier, we should be excelling at the management, the treatment. We should be writing the protocols. We should be excelling at everything about the management of sickle cell disease, especially the pain crisis of it all. I'd just like to say a few things more. Earlier on, I have seen a lot of people here today talk about their greatest advocates, and it's been their mothers. Where are all the daddies? Why are the dads not being thanked today for being advocates in the care of their children? A significant proportion of the people that I personally know who have sickle cell disease actually don't have their fathers in their life. And I just think that's really unfortunate. That's so sad, because no one of us is defined by the condition that we're born with. Some people might not have sickle cell disease, but they might have hypertension. So you cannot deny yourself the love of your child or the opportunity to love your child and be there for your children. It's like PTA meetings and not having the fathers in the room. You attend PTA meetings and it's 99.9% female, and the teachers and the children and the daddies are at work. So let's encourage the males that we know, especially as medical providers, to be in the lives of their children, especially when we are treating the young ones, the pediatric, patients. We should encourage family interaction and engage the family in the care. Another thing I know about our management in healthcare as healthcare workers is that nobody works in silos. So as Dr. Kalajaye said, sickle cell disease management is multidisciplinary. Like, it's got a lot of people, from the psychiatrists to the psychologists to the counselors to the hematologists, the internal medicine physicians, to the surgeons, sometimes, burns and plastics units for like the leg ulcers, surgery, a lot of fields actually involved and closely linked with it. And so it's very important that we all come together, and I'm really pleased to be part of this. I'm sure we've all learned a thing or two. I like how Professor Marina said that we do not heal alone. I really felt that. We all have a stake in this, and we're all together in this. We all have to work hand in hand, side by side, to really help each other to manage the pain in sickle cell disease. I want to say a very, very big thank you to a lot of people today. Let's start with Dr. Olowo Jabuti. I don't see him on the seat anymore, but we still want to thank him for his involvement. The chairman, NMA Lagos Zone. Very, very glad to have had him here today. I want to thank Dr. Niyi Ogundipe. It was a very interactive session. I learned a lot. I would still be happy to learn more. So Dr. Clement Innocent, who joined us and sacrificed sleep, with Professor Marino, who also sacrificed sleep. That was really considerate. Dr. Rotimi Agbol, I'm sorry, I don't mean to, but really want to thank him, the Director of Disease Control at the Lagos State Ministry of Health. We're very thankful for the presence here. We want to thank Dr. Bosede Wellington of Sickle Cell Disorder Program, the program manager. Want to thank Dr. Kalajaye. I want to also thank Dr. Adeyemo for all the lectures. I want to thank Dr. Bodorin Chikomaya, Dr. Lawson, Dr. Tigbo. I want to thank Dr. Emeka for his address. Want to thank Peter Oshikoya, who is a genetic counselor. I want to thank all of the collaborating partners, especially the people from Sickle Cell Health Initiative, the people from SAMI Sickle Cell Advocacy and Management Initiative. I want to thank the people from Neverna, and of course, I want to thank my colleagues, the A team at Exin Research. You guys are awesome. Everybody is awesome. Thank you. We all should just clap for ourselves right now, really. We're taking a step in the right direction. This is the first of hopefully many, many, many such summits to improve the care of sickle cell disease patients, in warriors in our region of the world. Let me just extend an invitation from all of us at Exin Research to the Impact Africa Summit, holding in December, 1st to 3rd of December. And we want to extend this because it's a clinical research summit, yes. And as Shola said earlier on, Dr. Shola did mention that, we are a research company, and we do believe that we believe very strongly in the inclusion of Africa in clinical research. The Europeans make about 16% thereabouts of the world population, and most of the research is done in Europe and the Americas, and that's just really unfortunate because we here get to use those medications and it's untested in our bodies, in our physiology. We have a very diverse population, very populous country, so we have both the numbers, we have the capacity, but we don't have the inclusion. We are not being represented. It's like politics. When nobody's representing you, anything they give you, you just have to take it like that, even if it's not optimal for you. So we need to be more, as clinicians, I know that we might not really want to be directly in the research part of things, but the research actually helps you to make impact across a very broad network of people. So you have the opportunity here. We all have the opportunity here to have direct contribution to change the way that we treat sickle cell disease. Some of the treatments that I am directly involved in as the medical monitor actually can prevent vaso-occlusive crisis, can heal and make better leg ulcers, can just do, it's really fantastic, the things that we're working on. And we are hoping that we will be having more interest in these areas. So we're inviting everybody to the Impact Africa Summit, and you can find us on the internet at Impact Africa Summit. And I'm really hoping to see a lot more faces there. We're going to have patient advocacy groups too. So we can continue some of the conversations that we started here today, especially with all the key opinion leaders that I have seen. And I'm going to be networking with everybody. So yeah, thank you all for coming again. And that's it.
Thank you so much, ma'am. Let's welcome Mr. Bamidele as he helps us to close this meeting officially with the national anthem that we started with. Clap for him as he comes forward. He's representing Nirvana Initiative. God bless you, sir. Just say.
All right. Thank you very much. It's been a wonderful day. And can we all rise for the national anthem so we can all go and eat and go home? The national anthem in 3, 2, 1. Arise, O compatriots, Nigeria's call obey, to serve our father's land with love and strength and faith. The labor of our heroes past shall never be in vain. To serve with heart and might, one nation bound in freedom, peace and unity. Thank you, everybody, and till we'll see you next time.
Thank you so much, Mr. Bamidele. Thank you. Network, connect, collect, and have a great evening. See you next time, next year. And don't forget Impact Africa Summit in December. Check their website, check their handle, Exim Research. Let's get ourselves on ground to enjoy all we have for quality healthcare.